We appreciate everyone being here tonight. We're grateful to have another expert speaker here with us at Melmark tonight. We hope the topic is useful for you guys. It's a continuation of our kind of theme throughout this year, or expert speaker year, regarding adult services and aspects of that to support individuals that are aging. And so tonight we're lucky to have Dr. Jonathan Baker here with us from Western Michigan University. Earlier today we were in a meeting and Jonathan was talking about some publications that have recently came out, and he wasn't bragging, so don't take it this way, but he was talking about how 4 of the 7 publications in this special issue that are coming up, he's a part of. And I share that with you guys, one, because he is cool, right? So he is the expert in the field, or one of them. But in the sense that there's a limited amount of research and a limited amount of application of this science to this population. And as Jonathan's going to talk about, one of the things we want to do is to increase that and keep it going through time. So I share that story with you because I want you guys to know I really do think we're lucky to have Jonathan here, and his history that he brings in terms of his training, starting at University of Kansas and Western Michigan, and then through his professional career in Illinois, and now he's back in Michigan. But I'm just grateful that he's here with us, and hopefully we get stuff on him in terms of improving our services at Melmark and elsewhere if you're visitors. So, quick couple of housekeeping things, and then we'll turn time over to Jonathan. If you haven't signed up already, we do have the CEUs. You can either get VACB or Act 48, or if you just want a certificate of completion, we also need you to sign up back there, so some employers like that for tracking other purposes. So anyway, any of that information, also the speaker feedback forms that we love to give feedback to our speakers. They value it often, and then there's portions on there about you guys giving feedback to all of Melmark in terms of what other topics and what other things you find relevant. So anyway, with that, let's welcome Dr. Baker.
Can you hear me? There we go. All right, well, thank you, Sean, for that wonderful introduction there. And this moves. Thank you, everybody, for coming and hopefully sharing some interest in the work that kind of has become my life's passion, which is working with adults and older adults, and in particular, older adults with neurocognitive disorder. So, started. Just a little bit of background on me. I started out working in basically the same area that many folks in behavior analysis do, working with children with autism. And it was a rewarding area, but it wasn't the area that I was really interested in. And through a series of just kind of dumb luck opportunities, I ended up at a setting where I was able to do a practicum experience working with older adults with intellectual developmental disabilities and or neurocognitive disorder, or what you may have heard referred to as dementia. And when I initially started working in this area, it was really for a letter of recommendation. It wasn't for interest in working in the area, and I really didn't think that behavior analysis had anything to add. And one of the main reasons that I felt that way was because in working with folks with neurocognitive disorder, you know that they have difficulty remembering. And to me, behavior analysis at the time was all about learning. And if we had a disease process that meant that someone could not learn new information, how could we apply the science to working with them? And I was just lucky to find out that there's actually a lot that we can do, and that learning continues at every level of neurocognitive disorders, all the way up until the disease has led to a person who's no longer able to talk or interact. We can still demonstrate some learning there. So that's going to be kind of the theme that I talk about today, is how we can apply this. And in doing that, again, it was just luck that I happened to be working with not only older adults with neurocognitive disorder, but adults and older adults with intellectual developmental disabilities. And it's become clear over the past 10 years for me that this is an area that many providers are recognizing as a direction that their services need to go, but there are very few opportunities, and Sean kind of mentioned that. There aren't many of us that are working in this area currently. If you're looking in behavior analysis, there's only 5 universities in the world that you can go to that you can find someone doing some of this. And I think that some of those are emphasizing it more or less. So I'm excited to share some of this with you. So the way that I always start this out is I provide a background scenario. So first thing I want to do is just with a show of hands, how many of you play some role in either writing behavior plans, implementing behavior plans, or something to do with behavior analysis with the folks that you work with? Spectacular. Okay. So I'm going to tell you about Joel. And Joel is a 13-year-old boy with moderate intellectual disability and autism spectrum disorder diagnosis. Joel has engaged in what we call escape-maintained problem behavior in the past, which means that that behavior, that problem behavior, was maintained by the termination of an activity, of something that was going on. Oftentimes it's academic tasks. And for Joel in the past, this intervention called functional communication training had worked really well. And with functional communication training, the individual is taught an appropriate response to engage in communicative response. It might be just asking for a break. It might be handing a card that says, I'd like a break. It might just be touching a button. But it's a way to communicate, I want a break. And we're basically teaching them, if you do this, we'll provide you with that break. If you engage in problem behavior, we're not going to provide you with that break. Is that feedback coming back to everyone, or just up here? I'll adjust and see. There we go. Okay. And when presented with demand, he could vocally ask for that break. So that intervention has worked in the past. And if you want to get super nerdy, these breaks were available on a multiple schedule, where we had signal times where reinforcement was available versus extinction. That's not necessary for that. Joel attends a special education classroom during the day. And what we've noticed is that he's decreased engagement in some of his preferred activities. And recently, we've seen an increase in non-compliance. And property destruction has also become an issue. So the idea is that you're brought in as the behavior analyst, and we want you to figure out what should we do with Joel. So I realize this room is a little bit bigger, and we may not be able to do it, but I'm going to try this out. For those of you who have some experience in behavior analysis, if you feel comfortable, just shout out, what might you think of doing for Joel? Yes.
Rule out the medical.
Rule out medical. That's a great place to start whenever we're working with any challenging behaviors. Rule out anything that isn't related to the environment. Anything else? I heard preference assessment. Somebody said it. Spectacular.
Medication issue?
Medication issues. Wonderful. We'll run with that. The idea that I wanted to kind of convey, and you all did it, is that this scenario doesn't present you with any major difficulty. You've got some ideas of where to go. We might start out in the area of assessments. We might do some preference assessments. We might also look at language and skill assessments. If there are academic tasks that are in this environment, we might evaluate the appropriateness of those academic tasks. And then we would look at medication and medical aspects of evaluations there. What are the goals that guide us? What are we trying to achieve for Joel? And how do we know what we should look towards for those goals? Well, Joel being 13 probably has an IEP that probably has some general goals that his care plan is working towards. We might also be able to look at peer-normed goals. So whenever we see non-compliance as an issue, we always want to ask, what's a realistic expectation? And realistic oftentimes is not zero non-compliance. We're all non-compliant at some point in our life. And many of us have the option to choose to just not do something and not be forced to then engage in it. So we want to look at how often are his peers engaging in different activities. And we don't want to set the bar higher than other folks that are in that classroom. As far as important parties that we might involve in that treatment decision, we would have Joel. Because remember, he could vocally request a break, so he may be able to provide some vocal input. We may also use just other aspects of his behavior to indicate preferences and things to work towards. We'd want to talk to his family. We'd need to work with the schools. And then there may be other services that Joel's receiving. We may have speech, occupational therapy, other professions that we may want to bring in. This is leading to wonderful forms of superstitious behavior, where I'm kind of like, if I go this way, it's the remote. Does it? Oh. I'll try to hold it down. All right. And then as far as guidelines and restrictions for what we can do and what we can't do, you might look to where I'm at. We have community mental health organizations for each county. And those community mental health organizations typically set requirements on what is acceptable and what is not acceptable within a care plan. We might have rules within the school district, and we might have general laws, federal laws or state laws, about how that care is provided. And the whole point here is that when it comes to services and supports for Joel, we have a pretty good idea of what to do. We may not get to where we need to be right away, but we know the direction to go. Well, let's change just a couple aspects of our scenario for Joel. Joel's now 63. Fast forward 50 years. Same general scenario, though. Escape, maintain behavior, communication training worked before, all that good stuff. He used to go to a workshop during the day, but he has stopped going to that. Staff aren't able to get him to go. He says he doesn't want to go anymore. And we've seen decreased engagement in some of his preferred activities. And recently, Joel has become increasingly non-compliant, and we see property destruction has become an issue. So once again, you've been brought in and asked to address these issues. So I could ask once again, where should we start, and what would we work on? My guess is that I would get pretty similar answers to last time. Medical evaluation, medical rule out. Oftentimes I don't get that preference assessment recommendation, but sometimes folks do. And if we're in a smaller group where folks felt really comfortable with the first one responding, I get a lot less responses for Joel. Like, what are the assessments that we would want to do maybe beyond the preference assessment? What are the guidelines that we look to? And that's where the audit usually gets pretty quiet. Beyond preference assessment, we don't tend to have great recommendations on what we should do, what we should look at. For our goals, what is the expectation for Joel? Joel's 63. And it may be that we don't need him to go to that workshop anymore. He's just about the age that neurotypically developing folks would retire. So should we be expecting Joel to continue to go to that workshop? Or is there something else that we could have him attend? Does he need to attend anything? Can he choose at that point to just chill? Who are the important parties? Joel's parents may still be around, but they may not be. We can talk to Joel. We can get some input from him. But beyond that, we don't have a school system. We may have other services and professionals, but an interesting thing happens as you get older. There's more separation of different services that folks receive, to the point where someone can attend 2 different doctors, and those doctors don't know what the other is doing. We can have one prescribing something that the other isn't aware of. And oftentimes we have to rely on pharmacists to catch some major issues that they may be experiencing. Yeah.
No, I think the role that one of our biggest things is once they're 21 in our city, they don't receive services anymore. So a lot of the children, they don't care about how they serve the children, and a lot of them receive like through school district that they attend, like speech, OT, physical. It's a point that services
Yeah.
Have services that he has.
Absolutely. So we've got folks that are visiting us virtually. So I'm just going to repeat real quick kind of what you said so that everybody in the audience gets it. Here in the state, there may not be other services that are available, speech OT, the way that they would be, was it 21, the cutoff age?
Yeah, I don't know about PA, New Jersey, the age out is 21 age, and after that, there's 80% of the services are cut.
Yeah. So at a very early age, those services are cut, and at best, you're hoping that just general Medicaid funding might pay for something. Speech pathologists might come in if there's been a medical event that might require. Oh boy, I'm not doing that. So there may be some services that are made available, but in general, we don't have other parties to interact with. When it comes to regulations and guidelines, that's another area that it's like, well, what do we need to provide? What needs to be made available? That works. Is that, ooh. I'm not ready. Just checking to see if I'm emitting radio frequencies here, folks. Yes.
I was going to say, what about like siblings that might be around that, could help?
Yes. So one party that we may be able to go to would be siblings. And we see that oftentimes siblings take over in the caregiver responsibility roles when parents are not around or available. So the idea at this point is what's going to guide what we do? Where do we move from here? And there are a number of areas that we talk about as being things that are aging-related issues that folks might experience. And this is going to be the topic of my presentation. I'll come back to Joel occasionally as I talk through some of these, because my hope is that by the end of this, Joel's scenario will not be one that you look at and say, I don't know what to do. Joel's scenario will be one that you say, I've got some ideas. I think I know there's for a direction that we need to go. There may be a lot more to it than that, but we're at least moving in the right direction. So I'm going to talk today about 4 general areas. Changes in behavior and looking at medical versus environmental factors. And this becomes extremely important whenever we're working with an aging population. I'm going to talk about neurocognitive disorder and maintaining independence. Talk about some general goals, overall goals and specific goals, and what might become the guiding factors for us determining that we've been successful in providing services. Guidelines and restrictions, and kind of where can you find this information. So, as an introduction, I often talk about this. The United States is experiencing something called the brain of the population, the brain of America. And it's not just that the United States is experiencing this. There are a number of countries that have actually already experienced this phenomenon. But right now, it's very relevant in the United States. And the brain of the population refers to an increase in the number of people that are over the age of 65. Currently, we have about 46 million people over the age of 65 in the United States. In 12 years, that's expected to increase to 72 million Americans. And at that point, 1 in 5 people in the United States will be over the age of 65. By 2060, we'll be at 98 million Americans over the age of 65. And at that point, it'll be 1 in 4 folks in the United States are over the age of 65. Now, why is this? Why are we seeing this brain of the population? There are a couple of factors. One is improvement in medical services. Another is improvement in surgery and medication. And those two factors in and of themselves lead to longer life expectancy across any population. But here in the United States, we also have a specific phenomenon that's led to this grain of America. And it happened between 1946 and 1964. Anybody know what that is? The baby boom. Yes, so we're talking about the baby boom generation. I don't have the graph on here, but if you've ever looked at demographic graphs, you'll see that they show the distribution of the population at a certain age, and then you can go by year. And if you do that, you can see the baby boom generation as this bulge in our population, and it just keeps moving up the ladder as it gets older and older. So we already have the baby boom generation reaching what we call older adulthood. And by the way, the idea of an older adult is a completely arbitrary term. We use the age 65 as indicating that you have become an older adult. There is nothing special that happens when you turn 65. There's no magical difference between 64 years, 364 days, and 65 years. It happens to be related to the original age at which Social Security was made available. So we consider that older adulthood. But when you think about it, our population right now, we've got a spectacular life expectancy that goes well beyond the age of 65, to the point that that group of older adults is a very large group. So, in the field of gerontology, they've split that group up into 3, now 4, smaller groups. So, from age 65 to 74 is referred to as young old. From 75 to 84 is old. And 85 and older is old. I don't know why they did that. It seems really insulting. But that was the breakdown that folks in gerontology came up with. And we're seeing an increase in the number of centenarians. So even old is getting to the point where we need to differentiate that out. When it comes to that increase in the number of folks over the age of 65, the group that is increasing the largest is actually the old. We're seeing the biggest increase in the folks over the age of 85. And along with age comes the possibility of experiencing chronic illness. Now, chronic illnesses are long-term illnesses that we know are related to certain health factors and certain genetic factors. But the single most consistent aspect of chronic illnesses is that they are age-related. As you get older, you are more likely to experience them. And 80 to 85% of Americans over the age of 65 experience at least one chronic illness. This includes visual impairment, blood pressure, cholesterol, mental illness, diabetes, neurocognitive disorder, and heart disease. These are the most common types of of chronic illness that folks experience. Now, when it comes to our aging adults with intellectual and developmental disabilities, we don't have quite as good information as we do with the general population. But we do have some information that we know. Not only is there a grain of our neurotypical population, there is a grain of our IDD population. Braddock in 1999 talked about the mean age of death, which is kind of a grim statistic to talk about. But the nice thing is that I've got really great news in this area. In the 1930s, the mean age of death for someone with an intellectual developmental disability was 18. By 1970, it was 59. By 1993, we were at 66. And as of 2010, we're at 73. So that is spectacular that we're helping folks live much longer than they ever did prior to those advances in medical services. And there's a little bit of an important breakdown. 73.2 is for folks with intellectual disability, but not Down syndrome. The number is slightly lower for folks with Down syndrome. But once again, along with increased age becomes important questions. We still have those chronic illnesses, just like we talked about for folks who are neurotypically developing. But As we pointed out, parents pass away, and parents are one of the most common caregivers for folks with intellectual and developmental disabilities. So we've seen an increase in interest in the news about what's going to happen to this population. So this article, which was What Happens to Developmentally Disabled as Parents Age and Die, talked about state approaches to addressing this major issue, and included passing laws that allow for funds for services for the older adult caregiver as well as the child with the intellectual and developmental disability, who I say child, but they are an adult, they're an older adult oftentimes at that point. When it comes to aging and autism spectrum disorder, this is where we really don't have much information right now. Some research suggests that autism spectrum disorder could constitute as much as 39% of all adults with intellectual and developmental disabilities. And the reason we don't know is in part due to the lack of effective assessment that existed really prior to the past 20 to 30 years, where folks who had autism spectrum disorder might have been diagnosed as having intellectual developmental disability, or a previous term that we no longer use, mental retardation. So we really don't know how much of this aging IDD population has autism spectrum disorder. But if we run out some statistics in preparation for what's coming, and run out our 1 in 68 children diagnosed with autism spectrum disorder, we can expect that by 2030, we should have at least 700,000 people over the age of 65 with autism spectrum disorder. So this was an interesting article that was talking about aging and autism spectrum disorder. And you definitely can't read that, so I'm going to read it to you. It says, 2 months before she died of pancreatic cancer in November of 2010, my normally strong, stoical mother broke down weeping in my arms over the fate of my autistic older brother. Institutionalized for over 40 years, Joshua, then 55, was in a stable situation and seemed relatively happy. But my mother was undone by the fear that haunts all parents of disabled children. What will happen to them when I'm gone? Though I hastened to assure her that I would become his guardian and watch over him after her death, she was inconsolable. So what are we doing about this? Well, not that much. The article goes on. But children eventually grow up, and children with autism have been growing for over 50 years. There is virtually no current substantive national conversation on the fate of middle-aged and elderly autistic people who are living in therapeutic homes, or with their aged parents, or in group homes, or sometimes undiagnosed in mental hospitals. And as Dr. Joseph Piven has said, there is almost no literature on older adults with autism in the field, so we virtually have no knowledge base. And this isn't new. In 1997, LeBlanc and Madsen wrote a paper talking about the need to prepare for our aging IDD and autism populations. So we've known that this was coming, but we've done little to prepare for it. They recommend that we should be looking at our assessments of dementia, and I have in parentheses neurocognitive disorder. I'll go back and forth between those terms. With the DSM-5, we now use the term neurocognitive disorder because there's more included in that than just the general types of dementia. And I'll talk about those in more detail. But if you see me talking about neurocognitive disorder, you can put that in an equivalence class with dementia. And it's the same thing. Question again? Okay. That's okay. Also, what are we doing as far as adaptive behaviors? Well, I can tell you with our neurotypically developing population, nothing.
No, I'm sorry.
I'm okay with questions throughout. I'm flexible.
Yeah, I just, no, they, I know they say you talk about this, and sometimes you're telling we don't use this in our but they talk about, let's say they have our pre-existing population, like, for the older adults, we'll
Yeah.
It has to be a score of 89, so it comes out development, a scale that we use to develop, the verification.
Okay, now I have a problem with your questions because you're stealing the thunder.
Oh,
That is a later part of my slide, and you should have read my mind to know that. It's fine. It's totally fine. So yeah, that's exactly something that I'm going to talk about, is assessment and the problems that we have with current assessments, what we need to do. And that's what LeBlanc and Mattson were identifying even then. I'll talk a little bit about our neurocognitive screens, but the majority of our neurocognitive screens are based on assessing verbal behavior, social interactions, and generally require a fairly sophisticated verbal repertoire. So since we're already talking about it, let me give you an example. I want you to repeat these 3 words after me. Everybody ready? Apple, table, penny.
Apple, table, penny.
Perfect. Okay. Now, I need a volunteer. All right. So, what's your name? Lara? Excellent. Lara, I have a task for you. I'd like you to count backwards from 100 by 7. $93? Anyone else want to help her out? 86? 79? 72? 65. Perfect. Okay, we'll stop you there. Anyone feel comfortable spelling world backwards? DLR, because you slow down. You go, ugh. What was that? So, what were those 3 words that I asked you to remember? All right. So the majority of you got that. If you just didn't even say it. It's okay. It does not mean that you have a neurocognitive disorder. This is just a screening tool. But that's a fairly sophisticated verbal repertoire that we need to be able to ask those questions. And you get different points based on your performance on those. So that was really what LeBlanc and Mattson were talking about there, is that we need to establish assessments. We also need to look at the assessment of mental health. And aging or not, we see that this is an area that is horribly underrepresented for our folks with intellectual and developmental disabilities. And there's a current national discussion on how underrepresented our mental health services are in general. But recognizing that we see even less for folks with intellectual and developmental disabilities. One that's not on there that I've seen a lot is also bereavement. And dealing with bereavement when another individual passes away. And you see where homes and staff don't know what to do when someone passes away and someone who's close friends with them is not aware of the fact that they passed away and asks about it, or even is aware of it and doesn't know how to cope with, my friend who has been here for a long time is available. And unfortunately, probably one of the worst things that we can do is just kind of sweep it under the rug and act like it doesn't happen. But it's what is the best approach for that. And we have very little research, and that's what they were talking about. And then the assessment and treatment of behavior problems, urinary incontinence, insomnia. Ambulation is not really a problem behavior, but it's often talked about as wandering. I have a problem with even wandering as a problem behavior. You've probably seen the quote, "Not all that wander are lost." How do you determine at what point someone is moving around aimlessly, which is the typical definition of wandering? That implies that you know the purpose, the intent of what they're walking around for, and oftentimes we don't. To me, it becomes a problem when they are eloping or going into an area that they shouldn't, or coming in contact with obstacles. So I'll use that as a more appropriate target behavior as opposed to just ambulation. And despite our initial call, we've seen few researchers that have developed approaches beyond 1997. But an important question is, what would that research even look like? What would we focus on? I'm just going to put my phone up here so I can keep track of time. and I talked about this a little bit in one of the meetings earlier today. We want to know what we should do for this population. How do we help them? But that leads us to ask the first question, which is, what makes this population unique that it needs to be studied in and of itself? If we're talking about aging, we have research on aging adults. If we're talking about neurocognitive disorder or chronic illness, we have research on that as well. If we're talking about mental health, we have research on that. If we're talking about behavioral problems, we have research on that. So what is it that makes it unique when we say this is for adults with intellectual and developmental disabilities? And oftentimes, what it comes down to, at least in my experience, is it's not so much that we can't understand what folks are experiencing. We can. But it's tying in the settings that folks are in with that knowledge and that research. So many settings that provide supports for adults with intellectual and developmental disabilities have very little training in aging and neurocognitive disorder. And settings that generally serve older adults who have some training in aging and neurocognitive disorder have very little training in how to support folks with intellectual and developmental disabilities. So to me, that's one of the important areas that we do need research on, is how do we blend those? How do we ensure that folks can provide services to someone as they age? Also, we run into the fact that we do see the manifestation of some illnesses and diseases at an earlier age for folks with intellectual and developmental disabilities than we do other populations. So that's something that we do want to work on. And I bring this up not so much to say that they are not unique or they're not important, but to say that instead of saying we have no research right now, one thing that we can do is look at the research that we do have and figure out how much of it is applicable and relevant and helpful and provide these supports. And then that will guide us in the direction of what is unique that we need to study.
Well, I was just going to say, also, I think we're at this point, but also, with some agencies, we have people who have specialized, genetic disorders. So they're living longer, and they present it in such a way that someone with credibility, they have some issues as they age, usually that they don't know how to address it. This is the first time they're like, living down 30,
Mhm.
living into their 40s, 50s, 60s, they don't really know what it looks like.
Exactly. So like Prader-Willi, which is a very specific genetic disorder. And I think in that case, we have a clear instance of this is a genetic disorder that we haven't seen folks living to and presents unique care needs and challenges. And I think in that sense, it's clear, yeah, we need to look at this. We need to identify. But some of our general intellectual developmental disabilities diagnoses don't always come with some of those very specific and unique genetic disorders. So we have to think about what we might look at. So one of the things that we talk about is that although I work in the area of behavioral gerontology, I have been told this many times, and I now finally agree with it. For a long time, I fought it. But I had reviewers and other people in the field saying, stop talking about aging, because aging is not relevant. And I was like, what are you talking about? Their point was, if you were to ask the audience, which I'm about to do, who is aging? Everyone. Everyone is aging. Time is not a relevant, independent variable. It cannot be, because we all experience it, and we all experience it the same way. So time cannot be the cause of changes. Now, we know that we age, but we don't age really because of the number of seconds, minutes, or hours that have passed along. We've got a couple of different aging-related theories. Does anyone know why we age? You ever thought of that? It starts to mess with your head. There are a couple different theories that look at the possibility that cells can only multiply a certain number of times, in which case it's not time that's relevant, it's multiplications, replications of cells. We also have theories related to DNA, and splits create more errors, and those errors over time create enough issues that aspects of the body no longer work. For the more so the women in the audience, Have you ever experienced marketing of things that are referred to as antioxidants, specifically for anti-aging? That's because antioxidants are believed to take care of something called free radicals. And free radicals are a byproduct of cell metabolism. So maybe it's not the number of times the cells split. Maybe it's when they're metabolizing and they're producing this byproduct, and we see an increase in that amount of byproduct, that then damages other cells. So there's so much junk in the intercellular tissue that eventually cells die. But we're still not 100% on any of those reasons, so we don't really know why. So that goes back to my whole, what are we looking at? Again, everyone's experiencing those sorts of things. So we have no real reason to suspect a substantial difference between some of the age of onset and the experiences outside of the setting and the supports that folks receive. So I'd like to make an argument that that's a direction that we really do need research. And it also begs the question, is there a difference in the efficacy of behavior analytic services? And I'm happy to say that no, there isn't. And if there was, I wouldn't have half of the publications in a recent issue, which was a special issue on behavioral gerontology. It turns out that we're able to do a lot. Sometimes it requires some tweaks. Sometimes we have to adjust what we're doing for the population, but in the end, it all works just as well. And that's pretty cool. And we may see differences in care approaches. So what do we know? Well, when it comes to looking at research, most of our research exists that focuses on older adults with dementia when we're looking at some of those age-related changes. So although older adults is our real interest, anyone over the age of 65, we already know that some of our best knowledge is more narrow. How narrow? About 5% of people over the age of 65 have some form of dementia. Flip that number around. 95% of our older adults don't. So we're already pretty narrow in our focus when we're looking at dementia. When it comes to older adults with autism versus older adults with autism and intellectual and developmental disabilities, most of our research is on older adults with autism and intellectual and developmental disabilities. So the areas that we do have information are pretty narrow. But I want to jump in and start talking about some of these things based on the research that we currently have. And the first area that I want to talk about is changes in behavior and starting to parse out medical versus environmental relations and aspects of those changes in behavior. So it's a common assumption among practitioners working with aging populations that behavioral interventions are going to be ineffective because medical conditions cause a continuous deterioration in skills. And with neurocognitive disorders, the assumption is that with memory loss, no learning is possible. Well, good news is that's not completely true. And that really follows from the medical model. And I'm going to talk about some of the things that Joel is experiencing and help you identify what things are likely biological, but what other things could be behavioral. And the neat thing about behavioral gerontology is that it's one of the few theories related to gerontology that actually has a positive outlook. When you take a medical model approach, part of what you're constricted by is how the body is adjusting and growing. And there's a term in biology called senescence. Has anyone ever heard of that? So senescence refers to essentially when your body stops growing. And you can kind of interpret that as the point at which your body starts to die, starts to deteriorate. Anyone want to take a guess at what age that happens? When do we see senescence starting to occur? Yeah, early 20s. So raise your hand if you're dying. Not the most positive outlook. But what an operant theory related to aging-related changes brings us is that although there are changes that are biologically inevitable, there are environmental changes that people experience that are avoidable, but they are occurring right now. And as a result, we're seeing enhanced deterioration of skills, much more than what it should be. And that a lot of the loss in functioning that we see folks experiencing may in fact be more related to the environment that they're in, as opposed to the fact that they're getting older. You always see where someone lives to be 100, they bring them on the news, the inevitable question, how'd you get to be 100? Oh, I smoked cigarettes and drank every day. That is almost always one of the common answers that we see. So it's like, what are they doing? We don't know. We have no idea. But the fact that we're seeing more and more people live to that age suggests that we are changing aspects that people experience. Because genetically, we haven't changed. We haven't done any major mutation that has led to us living longer. We've changed the world in which we live. So that's good news. So as I said, we have a number of different chronic diseases that folks experience. By proportion, arthritis, hypertension, hearing impairment, heart disease, diseases of vision, orthopedic impairment, diabetes, visual impairments. These are common chronic illnesses that folks over the age of 65 will experience. I'm going to talk about non-chronic illnesses as well as chronic illnesses by sense modality, recognizing, of course, that there are more than 5 senses, not a sixth sense, but science has recognized we have a number of different things that go beyond those 5. Digression. Okay, so vision. Poor visual acuity, where a person can't see as clearly at distance, typically correctable by glasses. I have been experiencing this issue since I was in 5th grade. And if I didn't have my contacts in right now, and if I didn't have my glasses in right now, this would be a fun presentation because it would mean I can't see anything that's on there, nor could I see the faces of the front row. I am darn near blind without my glasses, but I have a way to correct that. Presbyopia, where you can't see as clearly when things are up close. Generally, this begins around age 40 or 50. You see the telltale sign of the arm getting a little bit further out when reading material. I've caught myself doing this, so I know it's coming. But again, we can use glasses. This is due to the lenses that lose their flexibility. Lenses in the eyes, not your glasses. And glare. As you get older, glare can impact your vision. And it's interesting to think about glare as impacting your vision. But direct light narrows a visual field, and the peripheral vision is limited. And one of the things that I talk to folks about is thinking about the lighting in the situation that, or the setting that folks are living. How is the lighting? Do we have a lot of fluorescent lights that produce a light at a low price, but also oftentimes produce a glare? We want to get folks to experience natural light, but if it's direct light coming from the sun, that can produce a glare that makes it difficult to see. We also have a number of visual diseases: macular degeneration, diabetic retinopathy, glaucoma, cataracts, and retinal detachment. Our older adults with intellectual and developmental disabilities experience the same changes in vision, if not more so, than the general population. A Lighthouse study looked at this in depth a number of years ago and provided us with some of the best data that we have on visual changes. There is a higher rate of cataracts for all individuals diagnosed with intellectual and developmental disabilities. Sadly, though, there is a much lower rate of receiving any sort of corrective service for that cataracts. Folks with Down syndrome experience all conditions at an earlier age. So how can they be detected? Well, vision tests, if possible, might be a direction to go, but oftentimes that requires a verbal repertoire. Can you see this letter? Can you read that line? The other thing you can look at is changes in functioning. So there are some potential telltale signs that we look for that may indicate changes in functioning. One of the clearest ones, stumbling. walking into things. If someone didn't used to do that and they do now, let's check their vision. But there may be other things that we see. Someone withdraws from activities that they used to engage in. Someone is not compliant with activities because they can no longer see what it is that's in front of them. We see social isolation, and we see that individuals become detached from general groups as well. So we're not going to jump back into Joel's scenario yet, but just based on that information, when you look back at Joel's scenario, I want you to be thinking about what might be relevant, what might be something that we want to look at for Joel. But let's keep moving. Let's talk about hearing. 50% of Americans over the age of 65 experience some level of hearing loss. And hearing loss can be caused by three general areas. There's normal hearing loss that's going to happen to any individual as they age. Hearing loss can happen also as a result of persistent exposure to a lot of noise, including noise pollution. And then acute trauma can also result in hearing loss. Presbycusis is age-related hearing loss of high-pitched tones. So there are certain sounds that are more high-pitched than others, like an S sound or an F sound or a TH sound. And we find that as folks get older, those are the sounds that they are less likely to be able to hear. Also, higher-pitched voices may fall in a range that individuals who experience this normal hearing loss might not be able to hear. So part of what I have to do when working with my students is making sure that they are projecting their voice in a way that's going to put it into a range that everyone can hear them. And sometimes that involves some coaching, especially for some of my female students who may have a very high-pitched voice and you've got to get them to go down. Getting louder isn't the point because you're still doing a louder high pitch. We need to drop you down an octave and then you might be able to be heard. So it's not that you have to yell at someone. You just have to talk within the range that they're going to be able to hear. Tinnitus, or tinnitus, depends on who you talk to, is a ringing, roaring, or other persistent sound in the ear. Up until recently, this was not considered curable. I have seen where folks have actually been able to get this taken care of. But you can imagine this is not only extremely annoying to have that persistent sound, that's going to impact your ability to hear what's going on around you. And our individuals with intellectual developmental disabilities are just as likely to experience the same age-related hearing loss, if not more so. Again, folks with Down syndrome may experience these changes earlier. And detection is made more difficult, again, for adults with intellectual developmental disabilities. You need to expose them to sound, and you need to be able to identify that they hear that sound, that they're responding to that sound. You're also going to have to put those headphones on that person that block out other noise, and that may be uncomfortable for that person to experience. So again, we see some telltale signs that suggest that someone is experiencing hearing loss. They may turn up the TV. We may see increased non-compliance. Decrease in participations they once enjoyed, and self-injurious behavior have all been identified as related to hearing issues for folks with intellectual developmental disabilities as they get older. Are those guaranteed to mean that? No. But they may be taken as signs to suggest that hearing may need to be evaluated. So once again, think about Joel. Smell and taste can also change. Where we see smell decline with age, which is tied to your taste. Food may taste more bland, may become more bitter, may require additional seasoning on food. I was first learning about this as an age-related change when I was an undergraduate, and my father-in-law at the time was only about 50 years old, and I noticed over the next 5 years how much he would add anything. He loves spicy food in general. but he would add some level of spice to everything that he was eating, things that he didn't used to do that for. And it's become quite clear that he has lost a certain amount of his smell. And that's the way he is finally able to taste his food. Most things are bland to him unless he has doused it in Tabasco sauce, chili peppers, or something else that he can finally sense, and that's how he eats a lot of his food. Again, similar changes for folks with intellectual and developmental disabilities. And it presents safety challenges. So this means that smoke or burnt odor is no longer detectable by smell, or may not be. Spoiled food may no longer be detectable by smell. And this can also affect the ability to sense thirst. Taste and thirst are believed to be related, and there's some schools of thought that believe that if you're experiencing hunger, one of the best things to do is to actually drink water, not just because it fills your stomach, but it could be a misinterpretation of that signal that is actually that you're thirsty. Excuse me. Related to changes in smell, when I was in graduate school, I was doing respite services for this wonderful guy who was 96 years old. His name is Pat, and Pat was awesome. He was just great to spend time with, and I would just basically be at the house and provide any supports that he needed. But he was generally able to operate on his own. I'd be off in another room. He'd come tell me when he wanted me to be around, otherwise he'd say leave and get out of here. But there was one day where Pat came and he says, "John, those pills you gave me were bad." Knowing that I had not given him any pills, I became understandably concerned and said, "Pat, what are you talking about? What pills?" And Pat, at this point, had some progressive forms of Alzheimer's disease, so there was generally some confusion. So maybe he just doesn't know what he's talking about. And he said, those white pills. And I said, "Pat, what white pills? Can you show me?" So he takes me back into his room, and he points to a box, and he says, "Those." That box was a box of mothballs. And he had taken 2 mothballs, thinking that they were pills. And although nobody in this room would likely ever do that because the smell is so strong, as soon as it gets close to your face, you would never let it get any closer. His sense of smell had decreased to the point that he could not tell. But once it got inside him, then he could tell. And it turns out that they're not poisonous. I thought they were. And I called poison control immediately. But they said, only 2? He should be okay. Beyond 2, though. Get him to the hospital. We also see changes in motor functioning and reaction time. When it comes to different sensory inputs, detection does not always mean immediate action. And that means that folks are at risk for things like falls. They can detect that they're off balance, but they can't react fast enough to catch it. And we see those delays increase with age unless someone maintains certain levels of physical activity. There's the old adage of you don't use it, you lose it. And we see that these declines in particular can be mediated through exercise and regular activity, but there still will be some declines in reaction time. We see that folks walk more slowly and they'll respond falling more slowly. And as a result, staff are likely to provide full assistance to get things done, rather than any sort of prompt hierarchy. I don't know about you, but I was raised to identify any needs of my elders and provide any support that I could. That's a part of respecting folks within your community. Hold the door, help them, maybe get them a wheelchair so they don't have to walk as far. And what we're finding is that that approach actually has an impact of increasing dependency. And I'm not encouraging you to leave people out to dry and say, "Oh, Baker said that you need to do this on your own." Don't do that. But being mindful of how much am I actually doing for this person? How much am I stepping in? And how often am I giving them a chance to complete this task on their own without me jumping in? When it comes to musculoskeletal problems, we see less flexibility, muscle weakness, osteoporosis, and osteoarthritis, all is occurring as folks get older. So in summary, our older adults with intellectual and developmental disabilities are as likely, if not more so, to experience these deficits, and they can be extremely difficult to detect. Even if they are detected, it can be very difficult to get them the necessary services. I worked with someone who staff knew that she had extremely bad cataracts, and saw, it was basically a scenario very similar to Joel, where she was no longer engaging in preferred activities. She was about to actually be kicked out of the day program that she was going to. They said that she wouldn't do the tasks, and then she'd get lost when she was going to the bathroom. They were worried about the onset of dementia, and what was going on. And through a pretty quick interaction, it was discovered that she had extremely bad cataracts, and they had never even thought to get that cataracts taken care of. They looked at it as, well, this is just a part of an age-related change. We were able to get her in for surgery to have that taken care of, and it turned out there was no neurocognitive disorder. She couldn't see, so she couldn't engage in the task they were putting in front of her. When she would go to the bathroom, there were no signs, and it was down 2 different halls. So she'd get lost, and she couldn't see where she was going and how to get back. So that problem behavior that was about to get her kicked out of there, that was believed to be the result of one disease, was actually the result of a different disease, one that they could actually do something about. So when we come back to Joel, and we think about some of the issues that he's experiencing, we see decreased engagement in some preferred activities, we see increase in noncompliance, and we see property destruction. Everything that we've talked about could be relevant to those behaviors. And before any behavior analyst jumps in and tries to address this noncompliance, you have to appropriately address the possibility that it could be a biological age-related change that might have a very simple solution. I throw in property destruction on there, and this is where I always like to zing the behavior analysts in the audience, because when I say, what should we do for Joel? Reliably, nobody says operationally define property destruction. Shame on you. Because this is taken from an actual experience that I had where someone was referred to me for property destruction. And taking my normal approach, I asked them to define property destruction. It was knocking over different items within the house. And knocking them over, to me, I was thinking, well, they're knocking it over. But it turned out that this person was walking into things and knocking them over. And guess what? That was a vision problem. So the reason that person was referred, property destruction, was actually breaking things because she was walking into things because she couldn't see. She had glasses, but it had been about 13 years since she'd used them, and staff didn't know where they were. Got her glasses, and holy cow, no more property destruction. Now, there's not always going to be that magic bullet, that easy solution. But just imagine if you had attempted to address this non-compliance through our typical approach as a behavior analyst, when the whole time they just needed glasses, or they just needed those cataracts changed, or they just needed some support for their hearing. I also want to talk a little bit about physical design, the environment in which someone is living. For the general population, for folks that are getting older, we see that living arrangements are generally not conducive to living with age-related changes. Oftentimes there's too much sunlight, too much fluorescent light that's going to cause a glare, too much noise that can make hearing much worse, clutter on the floors, loose carpets, lack of handrails, all increase the chances of falling. We're getting better as a society in recognizing that the environment that someone lives in needs to change as they get older to support independence. But oftentimes we're not thinking about that. Just this floor, for example, slippery, chance for falling. Also, if you look down at it, you can see the glare from the lights. These lights aren't that bad to us, but if you have some aspects of different visual diseases, this may be too strong of a glare. And now I can't look up and I can't look down. And I get it at both angles. And many nursing homes even fail when it comes to preparing the environment for older adults. Items are unavailable. Things that someone might like to do aren't readily available. Staff have them locked away in some different room or some area. We see seating arrangements aren't conducive to folks maintaining any level of interaction. You see where folks are just kind of lined up along the walls in common areas. And signage, actual signs, so that you know where you're going and what you're doing, is often missing. So Sloan et al. Created this thing called the TESS-NH, and it's just a survey that you can use to evaluate the living arrangement that someone lives in. And this is the NH, so it's specifically designed for evaluating nursing homes. But it has questions like this. To what extent does the unit facilitate wandering? Note they said facilitate wandering. Because we shouldn't be discouraging folks from engaging in physical activity. We know that they need physical activity to maintain physical activity. So, is the unit set up to actually support that? By the absence of dead ends and the provision of places to sit along the corridor. So you get points based on how well your unit is designed. If you have a path with no dead ends, you get a point. If you have a path that leads to a dead end or an alarm or a secured door, you're going to lose points. And if you think about it, if someone is walking around and they may have some impact in their mobility, getting to a point that they have to stop and then turn around requires pivoting and balance. If they can just keep going, we don't see that as an issue. Also, if you want to keep people from wandering out of your facility and you have a hallway that leads to a door, the behavior analyst in the room, there is no better discriminative stimulus than a hall that leads down to a door. That's where you get out. Just go. You can make it. And also, are there places to sit? So it's just giving points on different areas. We've got, for the rooms themselves, are the doors left open or are they closed? Is the resident's name there? Is there a current picture? Is there an old picture? What we've found is that for folks who have neurocognitive disorder, if you present them, actually a friend of mine, I think this is in that special issue, a friend of mine was looking at how likely people are to recognize themselves and presented with different pictures, and reliably older adults with neurocognitive disorder will recognize themselves in their 20s and 30s, maybe into their 40s, will not recognize themselves as they currently look. So just putting a current picture of them on the door wasn't enough to help them remember, because they would actually look at that person and say, I don't know who that is, but that's an old-looking person. And then they'd see a picture of them as they were younger. That's me. I remember that. Also, identifying colors or color coding. It is amazing how many facilities that I've been in that I've got lost when walking around. And I can't figure out what unit I'm on or what hallway I'm on. So you can get more points for those, and I won't go into all of them. I also want to talk real briefly about mental health and the potential that behaviors and declines could be related to mental health issues. And I won't spend too much time on that. But there's a common belief, and I promise this will tie back in, but there's a common belief that autism symptoms lessen with age. And I thought that sounded like one of the most ridiculous things in the world until I got out and started talking to people. And they thought, yeah, well, autism gets better as you get older. One, I don't know what they mean by it gets better, and number two, I just don't know what they're talking about. But it is something that I interact with. So community-dwelling individuals with autism are already adjusted for life. So why should we worry about aging? They're already doing fine. I don't know that you can say not receiving services means they're doing fine. Could be that they would have benefited from services and our funding situation just doesn't allow for those services. But Happy et al. In 2016 looked at characteristics of adults with autism. And when they were looking at the severity of symptoms across ages, the oldest individuals that they worked with had the most severe symptoms. They saw the most severe social deficits, most severe communication deficits, and the least flexible thinking. Now, is that because age makes autism symptoms worse, or could this be what we call a cohort effect? Whenever you look at aging research, there's two different types of studies that people do: cohort designs or longitudinal designs. Cohort design, you're looking at people at age 20 to 30, 40 to 50, 60 to 70. Each one is considered a cohort. And when you identify differences in those, there's a potential logical fallacy that you can fall into, where you assume that the difference between the groups is related solely to age. But it could actually be a cohort effect. And there's a great chance for a cohort effect being related to this, because how many of those older adults were given access to any services when they were younger? So we're not going to look at this as age causes this, but it definitely does not support the belief that symptoms are getting less as folks age. And again, we've got communication, social deficits, communication deficits, and the least flexible thinking. Now, in the broader gerontology literature, one of the things that folks are really interested in is quality of life. And quality of life is this very difficult to define concept. How do we know that someone's experiencing quality of life? That's kind of like the goal. You want to get to retirement age and you want to just be happy, live out your life happy. So they talk about quality of life. And most of the research that's looked at quality of life has identified a couple of key variables. So it's not that quality of life is retiring in Florida. For some folks, that's the life they want. For others, that may not be the life that they want. For some people, it's saying bye-bye to the kids. We're off to live our wonderful life on a cruise for the rest of our lives. There are now cruises that are available for living options for folks as they get older. You kind of want to do that. But they look more at specific behaviors that seem to cut across different areas. For these folks that find happiness, what is it that they have in common? Well, one of the most common things that they see is the ability to handle stressful situations and change has been associated with folks who report they have a high quality of life. They're happy with the life that they're living. And this other thing called selective optimization and compensation. And selective optimization and compensation refers to a process that we see happen. As folks experience age-related changes, they can't do everything that they used to do. So they're going to select the things that are most meaningful to them, and they're going to do everything they can to continue to experience that in some way, shape, or form. And then they're going to compensate for the things that they cannot do, find ways around it. So if one of my passions was getting outside and walking around in nature, I'm going to work hard to find ways. Maybe I have a friend or a family member who can take me out to go see some of the woods or the forest that I like to go to. But something else that I used to do, grocery shopping, wasn't my favorite to begin with. It's difficult to do now. So I'm going to find a way to compensate for the fact that that's just not going to be my passion. I'm not going to work at that. I'm going to focus on making sure that I can get out and do the things that I enjoy. That's selective optimization, compensation. And research suggests that aging adjustment could be more difficult for individuals with autism if these two things are key aspects of quality of life. Because as we said before, when we're looking at our oldest individuals with autism spectrum disorder, we see deficits in social deficits, communication, and the least flexible thinking. Yes?
Oh, I'm sorry. I know, I was just talking about family involvement that seems to play a role in behaviors and the importance. And do you think that plays a role in as get older and their ability to adjust and handle difficult situations?
I think it does. I think this sample in particular was a little bit biased in that they were working with folks who might not have had many other supports. So it may be that they missed that in the study. We also see, there we go. Higher rates of anxiety and depression reported for folks with autism spectrum disorder than we do typically developing populations. As high as 33% of folks reporting rates of depression and anxiety. That's much higher than what we see or would expect in an aging population. We do know that cognitive behavioral therapy has been shown to be effective when working with older adults. And is an empirically supported intervention for depression and anxiety for older adults. And we've even started to see folks applying this to work with older adults with neurocognitive disorder. And it does require some modifications. There aren't the expectations of progressing through different aspects and stages as you would normally. But researchers are showing that we may be able to provide supports, and that's important because we know that rates of depression increase as folks experience neurocognitive disorder. So on that note, let's talk a little bit about neurocognitive disorder. Now my plan was just to keep on talking. I'm going the full time here. So if at any point you need to use the restroom, by all means, go for it. I will not be offended. Neurocognitive disorder affects about 11% of men and 16% of women over the age of 70. It's only about 5% over the age of 65. And neurocognitive disorder is not one disease, but it's a collection of different diseases with some similar impacts on the individual. So you want to think of neurocognitive disorder, or dementia if you want to use that term, as an umbrella term. Under that umbrella, we have a number of different diseases, including Alzheimer's disease, vascular dementia, Lewy bodies dementia, Pick's dementia, frontotemporal dementia, HIV-related dementia, and there are many others. But all result in a general loss of abilities, memory impairment, and impaired judgment and abstract thinking. Current criteria for a diagnosis of a neurocognitive disorder, and neurocognitive disorder, when we were using the term dementia, folks referred to stages of dementia. I don't know if any of you have ever heard of different stages of dementia. We moved away from that. We don't talk about stages anymore because there was no clean progression from one stage to the next. You could see someone with aspects of mild and aspects of moderate and aspects of severe, all in the same person. So they moved towards just minor or major. And the key difference between minor and major is whether it impacts your life on a day-to-day basis. If it does, it's major. If it doesn't, it's minor. And we're looking at deficits in complex attention, where normal tasks take longer to complete because you can't keep at that task. You get easily distracted. It takes longer to get through it. Executive functioning, where we see an increased effort for multitask projects. So getting through something that requires you to keep track of what you're doing and has many different steps. You complete one step, and now it's time to do the next one. I oftentimes think of like grocery shopping. Grocery shopping as an example of this. I need to write a list. I need to go to the grocery store. I need to have that list. That is usually the key flaw in my plan. And then I need to find where everything is in the grocery store while checking things off that I've gotten, and then purchase it and get home. So that would be where we'd see increased effort for completing those. Learning and memory, we see difficulty recalling past events as well as current events. So things that just happened are even less likely to be recalled than previous events. Changes in language, oftentimes you see a noticeable word-finding difficulty that wasn't there before. And you see filler statements like ums and does and the thing and that, that thing. As you start to see some of those developing, that could be a sign of neurocognitive disorder. Perceptual motor, where you might need support for familiar activities. When presented with an activity that you used to do, you may not be able to engage in it anymore. And then social cognition, subtle changes in behavior. So these are the different areas that now with the DSM-5 we look at for those changes. And if we see changes in those areas, then we might have a neurocognitive disorder. Now there can be reversible as well as irreversible forms of neurocognitive disorder. So about 10 to 20% of neurocognitive disorder is actually reversible. It's referred to as delirium. And it can be caused by a number of different things. Medication can cause delirium. Tylenol PM, for example, can actually have an impact on someone if they take that regularly. They can have a delirium effect. Vitamin issues, electrolyte issues, depression, hypothyroidism, hydrocephalus, Korsakoff syndrome are all reversible forms of neurocognitive disorder or delirium. One that isn't on this list, but that I've seen fairly regularly, is actually urinary tract infection, where folks who experience a UTI, we see this drastic change in behavior. And it's probably one of the most basic things that I always push for whenever someone has been referred for a new behavior is, do they have a UTI? And it's unfortunate when folks don't check for that, especially when that person needs to be hospitalized and the first thing the hospital comes back and says, they had a UTI. And as much as I would like to revel in the fact that I was right, but we still didn't help that person. But the majority of neurocognitive disorders are irreversible. And I already talked about many of these, so I won't go into that too much. Alzheimer's disease is the most common form of neurocognitive disorder. It accounts for 60 to 80% of all forms of neurocognitive disorder over the age of 60. Currently, about 5 million Americans have Alzheimer's disease, and that's predicted to increase by 2050. And people tend to live 8 to 20 years with Alzheimer's disease from the time of diagnosis until the time they end up passing away. We don't know how common Alzheimer's disease is among folks with intellectual and developmental disabilities. We do know the prevalence for folks with Down syndrome. At age 40, 5%, actually I've seen that number is actually much higher now. And then around 56 to 60 years, we see about 45%. So neurotypically developing populations, these numbers would correspond to, instead of 40, say 60, and instead of 56 to 60, that would say 80. And those are similar forms of prevalence. As far as why we see this specific prevalence for Down syndrome, the belief is that one aspect of Alzheimer's disease can be related to apolipoprotein E4. It's a specific protein that's carried on a specific chromosome. And there are different types of that apolipoprotein, and if you have that E4 one, the chances that you'll have Alzheimer's disease are drastically increased. Well, the chromosome that's carried on is the 21st chromosome. And folks with Down syndrome have trisomy 21, so they have 3 of that chromosome. So that is where one of the beliefs for that increased prevalence of Alzheimer's disease for that population comes from. The course of the disease appears to be generally the same for folks with intellectual and developmental disabilities, but it's difficult to map onto deficits because of existing knowledge of the disease. Many deficits require skills that folks just might not have had for us to identify that there's been that progression. It doesn't mean the disease process is different. It just takes longer for it to manifest. So for folks with more complex verbal repertoire, they can engage in behaviors that can essentially hide that neurocognitive disorder. They can compensate for memory issues that we think folks with intellectual and developmental disabilities can't compensate for. As far as how it's diagnosed, we start with a documented memory impairment, and then we move into neurocognitive disorder screening instruments. and the decline in cognitive abilities as measured by neuropsychological tests. So ideally, we would see this progression. If we document memory issues, we'll do a screener to see if more assessment is necessary, and then we get a solid neuropsychological battery to identify whether or not a neurocognitive disorder is in place. Oftentimes, folks don't get access to that last part, that neuropsychological assessment, that key battery. And the majority of folks that I work with, either with intellectual and developmental disabilities or not, tend to get the diagnosis from a medical doctor without a lot of follow-up. Question?
No, I was just going to say, with the document memory problems, in terms of the cognitive abilities that they already have,
Yep, they're coming.
you're already on
Sorry. I'm just gonna say with the documented memory problems and stuff like that, because of that cognitive delay, that would seem to be hard to be picked up on. One of the things, because we serve individuals who have advanced dementia, learning as we go along, and we actually had to develop training to train our staff on what to look for, and actually a lot of the stuff, thank you very much, you brought up, we were able to put in and train our staff on and talk about some of the things that they can do to increase the quality of life and decrease falling and all that good stuff. But we were talking about, we told them to look at the behaviors, like where their baseline is, like what things that they're able to do, if they're able to do, like certain, like, I don't know, brush your teeth, they can do it independently, and they start noticing that they forget to turn off the water, or they mess up certain steps of the chain, or they forget certain things. That's how we look at it as opposed to the memory issue, because of that delay.
Yeah, and that's a key component. So I already gave you the example of the different screening tools and kind of the questions that you would experience. And, sorry, what is your name?
Tanya.
As Tanya has said, we can't rely on that. When, I think you can just switch it off. Maybe a little, perfect. We can't rely on these as a way to assess for neurocognitive disorders. So what do we do? Well, there are a number of assessments that have been specifically developed for adults with intellectual and developmental disabilities. What has been considered kind of the hallmark is the dementia scale. Should never look at a laser like that, but I just did. The dementia scale for Down syndrome. The dementia scale for Down syndrome, though, generally requires that you have to be a licensed psychologist to administer it. So the other ones that I have here, the DMR, the Schultz, and the ABDQ, are all more readily available. And each one of those does exactly what Tommy said. It establishes a baseline. And that becomes the key way to identify neurocognitive disorder for folks with intellectual and developmental disabilities. But the key to do that is establishing that baseline before they have signs of memory problems. So this means that really, if you're providing services to adults with intellectual and developmental disabilities, you should be establishing that baseline around age 40, if not mid-30s. And that's generally done by administering one of these assessments about every 6 months to a year. It's an interview with caregivers. And it's exactly what she said. It's asking about things that they do and identifying what can this person do on their own. And over time, when we see declines in what they can do on their own, enough of those trigger a score that suggests that neurocognitive disorder may be present. And then ideally, we would still see that neuropsychological assessment. There are some places that specialize in doing those for folks with Down syndrome and intellectual developmental disabilities. But that also helps, even if you can't get access to one of those, for you and your staff to identify there are changes that are happening. And we should look at, are there things that we can do to support this individual? And the problem is, with all of these, if you start to administer them once you think that there is an issue, that becomes the baseline. And it almost always results in that person not getting a diagnosis when you administer that assessment the first time, because we don't have that historical data. And it usually involves interviewing a caregiver that's known that person for at least 3 years. And when you think about staff turnover, you may not be able to find someone who's known that person for 3 years. So administering these early on and getting that archival information will allow you to identify those changes, even if we see changes in staff. But what about maintaining independence? Well, I'm not going to focus too much on some aspects of independence. But I'm going to talk about some of the challenges that we see folks experiencing, both folks with autism spectrum disorder and without. But adults with intellectual developmental disabilities and ASD tended to have lower levels of adaptive functioning and more problem behaviors as they got older. And the disruptions of all quality of life outcomes, other than the frequency of social interactions and community activities, also significantly different. And in all cases, folks with intellectual developmental disabilities and autism tended to have lower activity levels. So what can we do? How can we get these folks engaged? And I see engagement as a form of independence and activity. Oops. And to understand this, we also have to think about the broader context in which someone is living. And for those of you who may be community partners who are here for this presentation, you may be more likely to interact with folks that are in many of these different living settings. So we see our older adults may be receiving in-home unpaid care. They may be receiving in-home paid care. They may be at a day program, an assisted, or some people talk about supportive living facilities, or a nursing home. Each one of these settings has different constraints on staff time and their ability to actively program for this. And we see that that becomes a key component in increasing activity engagement and, along with that, a form of independence. So, I took this picture from a nursing home website, and that looks like a fun nursing home. I believe they're having a race, and she won. And we've got folks clapping in the background. I believe that over here on the right-hand side, we may have a bird cage. Nice fun area where you can hear birds, you can do scooter races. It's a great place to be. Unfortunately, that is not what most nursing homes are like. In 1975, McClanahan and Risley looked at the design of living environments for nursing home residents, increasing participation in recreation activities. And the first thing that they did was collect data over 2 weeks on social interactions. And this is their graph, and it's a little grainy, but on the y-axis you have the mean percent of social interactions. And on the x-axis you have different categories. That first one says none. 87% of residents in this nursing home over a 2-week period of observing for 12 hours a day engaged in no social interaction. When they did, it was with another resident or with their self, occasionally with staff, visitors, or the observer. The observers who were there to collect data were getting as much interaction as staff were. And, so you're thinking, well, this is 1975. We're well beyond that. This study has been replicated twice, once in the 90s, once in early 2000s, same results across different facilities. In fact, the 2002 study, if I remember correctly, was done across 10 or 15 different nursing homes. And aggregate, same thing. What's great, though, is that we have an entire literature starting in the 70s looking at increasing social interaction as well as activity engagement. These first two, Lackenhau and Pinkston, and Troche, Tubin, and Jason, all they did was they provided refreshments. They set up a table and they gave them coffee and cookies. And as a result of that, folks came, aggregated around the table, and interacted. Troche Tubin also looked at the seating arrangement. So if folks are sitting along the outside of the wall, they're less likely to interact than if we have them at a circular table where they can see the other person and then interact with them. Michelle Bourgeois looked at enhancing conversation skills in patients with Alzheimer's disease using a prosthetic memory aid. And that's a fancy name for, she gave them a book. And that book had information about that person. That was the intervention. Here's a book with information about you. And you really can't see that all that well. But if you look at it with one eye closed and kind of squint a little bit, you'll pick up some general aspects of it, where you see things are low in baseline. I'm good at aiming this thing. Definitely not. Oh well. Things are low in baseline. Provide the memory aid, things are higher. Those things are social interactions. They are on-topic statements and interactions with other folks. And then we see that this maintains over time. And this is across participants as well. So just providing them with a memory book resulted in better social interactions. Gallagher and Keenan looked at extending high rates of meaningful interaction through participation in specifically designed activity. That activity was on a placemat. They provided them with placemats that had a game on the placemat. And what they were looking at, this is a funky graph. Along the x-axis, it says time from noon to 3. But you have to think about it. Look at the top where it says A, B, A, B. For the A, we have averaged 15-minute blocks. And it's looking at the number of meaningful interactions. So on average, at noon, there was only about 5 meaningful interactions at the beginning of that A condition. It kind of goes up, and we see a peak just around 1, and then it falls off. Move into B, same time period, we see sustained high interactions across the board. So can everybody see that? Does that make sense? And then you go back to A, it goes back to what it was before, go back to B, and it's better. And that's all from providing a placemat that had a game on it. Pretty cool. Engelman et al. Looked at increasing engagement in daily activities. Oop, I don't have that graph, so I'll describe it to you. So what they did was conducted a preference assessment. Actually, I think they did not conduct a preference assessment because Engstrom, who followed up later on, did conduct a preference assessment. But it was present opportunities to engage in different tasks. So a multiple baseline design across morning and afternoon, where staff were taught to use prompts and praise to increase engagement. And what that meant was check in every 15 minutes, ask them what they want to do. This or this. And we saw drastic increases in activity engagement. And these were for folks that the nursing home reported did not engage in activities, couldn't engage in activities. Well, if you present that as an open-ended, what do you want to do? You don't get much. If you know what that person might like to do and offer choices, you're more likely to see engagement in those activities. But what about the items to offer? Well, we have plenty of research looking at preference assessments with older adults. Caregiver interviews, paired stimulus, multiple stimulus without replacement, free operant have all been demonstrated to be just as effective at identifying preferred stimuli for older adults as they are for the young kids and the adults that we work with. So that's great. You don't need to modify anything within your repertoire. You can start using those immediately. Some of the cool distinctions, though, that folks have found, LeBlanc et al. 2006 found that a pictorial paired stimulus preference assessment, meaning just showing pictures and asking which do you like, worked just as well as providing the items. And that kind of goes against what we know about how you should do a preference assessment, like the items should be there. Well, it turns out for folks without an intellectual developmental disability, you don't necessarily need to do that. Veras Ortega found an interesting phenomenon when it came to their paired stimulus preference assessment. There was a study that Bojack and Carr did in 1999, I think, or early 2000s, where they were looking at when you conduct a preference assessment and you have edible items and leisure items in the same preference assessment. And what they found was that when you have both of those in the same preference assessment, edibles were winning out. Like across the board, it was edible, 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 leisure, 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 leisure. Nice split. And what that led to was a false negative, meaning that that last preferred stimulus, or really all the activities, were implied to be less preferred and not as effective as reinforcers. But what was happening is what they called a displacement effect. The food was displacing the leisure activities. And they recommended that you do them separately. And if you do, you can find great edible preferred stimulant and great leisure preferred stimulant. Well, Vera Ortega looked at that with older adults and found the reverse. They found that leisure items displaced edible stimuli. And I've got a study with one of my students that we're hoping will come out not too long from now, where we replicated that. And for the person that we were working with, he even said to us, I've got food. I don't need that. I don't get to play this game. He didn't say it quite like that, but that's basically what he was saying, was that, these are the things I don't have access to, and that's what I want. And that initially might lead us to say, with age we see where you like to do leisure items over edible items. Probably a more parsimonious explanation was that the facility that he was at was great at giving meals. This was in southern Illinois, so we are considered part of the South there. So it was fried chicken, there was grits, there was great stuff. That was breakfast. Then there would be a snack. Then it was lunchtime. Then there'd be a snack. Then it was dinner time. Then there was a snack. He didn't need food. He had lots of access to food, but activities and things to do, he didn't have access to those. So when you think about these displacement effects, it's not so much that one is aging related, it's setting related. A colleague of mine, Joel Ringdahl, described it as an open versus closed economy. What do you have access to regularly? What don't you have access to? The things that you don't have access to regularly may displace the other things. And the reason that you would do a preference assessment might vary for our older adults. So a lot of times behavior analysts do a preference assessment to find out what will function as a reinforcer so we can use that in skill acquisition. Well, I'm excited to tell you that we have some research already looking at skill acquisition for folks with neurocognitive disorder, and we are getting skill acquisition, even as folks are declining. But there's generally a different reason that we do preference assessments for older adults, and that's simply to find things that they would like to do, to give them meaningful activities to engage in. So we'll do a reinforcer assessment, but we're not looking at providing that stimulus contingent upon, engaging in some sort of task. We look at how long does that item keep you busy? And we look at engagement with that task as a measure of the reinforcing aspects of that stimulus itself. So we'll use different preference assessments. We'll probably use a free operant if I'm looking at what might you like to do. Whereas I might use an MSWO or paired stimulus if I'm looking to identify things that you'll engage in to get access to, because the assessments themselves almost lend to that. A free operant is an engagement-based assessment. It's not so much what do you select, but it's what do you select and how long do you engage with it. MSWO or paired stimulus, we're looking at what is more preferred over the others, so you will engage in a behavior, in this case a selection, to get access to that over the other things. So we've got a couple studies looking at the potential that different preference assessments might inform the different levels for the different things that you want that stimulus for. Also, looking at the level of functioning and the verbal repertoire. So, a lot of times in nursing homes, I see a one-size-fits-all. I've been so excited as I've toured the different buildings yesterday and today to see individualized activities and activities matched to people's functioning level. So at a single table, we might have one person who has spectacular fine motor skills, and they're working on tying a bow. Another person who doesn't is organizing the different things that person is looking at tying together. And promoting engagement by identifying what a person can do and giving them items that would be relevant to that. That really puts you all far above many of the facilities that I've toured and worked at. Both for folks with intellectual and developmental disabilities as well as just general nursing homes. Bingo is everywhere. And then I talked about access and displacement. So, many BCBAs, the skills that they have from working with the IDD population will apply quite well to our aging population. But you may need to make some tweaks. You just have to be aware of the potential that you have to look at it a little bit differently. Already talked about that. This is a decision tree, and you don't need to worry about reading it. Don't worry about that at all. But this is from a study that former student of mine, Amanda Buckmeyer, did, looking at successfully conducting a preference assessment with folks with intellectual and developmental disabilities who had been identified as having extremely narrow preferences and not being willing to engage in anything else. And the BCBAs at that setting had essentially given up. They said, we can't do a preference assessment. They always do the same thing. It doesn't work. And what we did was we worked with 5 different folks that were in this, they called it the senior club. But everybody who was in the senior club had only one item that they would engage in. So every day it was come in, engage with that one item. And we said, well, what else could they do? They said, well, you can't find anything else. There's nothing else they can do. So we created a decision tree of kind of working through identifying a preference. And this builds off of a publication from Amanda Karsten and colleagues, where it was, what preference assessment should you run and how do you decide to progress through those? And she talked about things like a side bias. And how that would impact it, or if someone engages in problem behavior, when you take an item away from them. And she gave a decision tree similar to this. But for us, it was, what if it's somebody who we can't really do, we can't get differentiated results in a preference assessment? How might we manipulate that? And this is our initial set of things that we did, all of which resulted in us identifying stimuli that we could then throw into a reinforcer assessment. And then this one is the series of decisions that were necessary to effectively set up a reinforcer assessment and get differentiated results. And again, you don't need to worry about reading that too much. This actually just came out yesterday. Super excited to see that. But so it's available. We can get it to you if you're interested. But the thing was, with everybody, we were eventually able to get to differentiated results in a reinforcer assessment that then led to another study that we're working on getting published, which was using something called a lag schedule of reinforcement. We differentially reinforced selecting new activities and exposing someone to different activities. And as a result of that, every one of the folks that made it to that part of the study started engaging with brand new items, not just in our sessions, but in the senior club, without being prompted, without us saying anything to them, by exposing them to it and providing differential reinforcement for selecting novel or new items. We saw different engagement.
Do you use, to reinforce what the reinforcer you delivered on the lag schedule, is that the original item that had been identified, or is it something different?
If I remember correctly, and I should have checked this before, but I want to say it was praise. We demonstrated that praise was functioning as a reinforcer, and that was the key to this, was that we wanted to see whether or not it was, and then use praise during the lag schedule. Other challenges that we see to independence. Independence during dressing or care tasks. And Mark Matthews and colleagues have shown, just like he did with that activity engagement, using that least to most prompting, works just as well during dressing and care tasks. And he did a really cool study showing that providing people with the opportunity to dress themselves, where you present the next step in getting dressed and use that least to most prompting strategy, resulted in complete independence for each of the participants, all of whom had neurocognitive disorder, and he kept track of how long it took to do the task. And it was shorter with the prompting hierarchy, which is really cool because staff actually then adopted that because it took less time to do than what they had been doing. And they really had gotten into the point where they were doing it for the folks because of the time that it saved. They couldn't get the individuals to dress on their own, and they've got a lot of people that they need to get dressed in a very short period of time to do it. So it's I'm jumping in, I'm helping you, I'm going to do it for you. Research on incontinence. Probably one of the more common reasons that someone might get placed in a nursing home if they're community dwelling. Caregiver burnout as well. And what Schnelly and colleagues have shown over about 13 or 14 different studies is this intervention called prompted voiding can completely eliminate incontinence. And prompted voiding is probably one of the most simple interventions that could ever exist. Take them to the bathroom. On a schedule. 2 hours. That's it. And they are no longer deemed incontinent because they will always be going to the bathroom on the toilet. Unfortunately, what he has shown is that this is almost impossible to get adopted into a nursing home. He did one study where he kept track of the amount of time that it took to do this, and he had more to it. There's actually a fairly complicated version of the study that he was doing, or the intervention. But what he showed was that if you're taking someone to the bathroom every 2 hours, then that meant in a 12-hour shift that you were taking someone to the bathroom 6 times. And he compared that to how often staff were taking someone to the bathroom normally. And in a 12-hour shift, they were taking someone to the bathroom 0.5 times. Now, how do you take someone to the bathroom 0.5 times in 12 hours? You take them once in 24 hours. But we can understand, if we look at the contingencies on staff, we can understand where that comes from. Where there are very few regulations on staff-to-client ratios in nursing homes. There's actually no national requirement on staff-to-client ratios, and states can set them themselves in nursing homes. And I've been in facilities where it was 20 to 1, 20 residents, 1 staff member. And when someone's faced with that, I completely understand. I don't like it, but I completely understand why that would be what they do. It becomes a one-stop shop. Tim and I were talking about it earlier. This is when you can take them to the bathroom. This is when you can bathe them. This is when you can change their clothes. And you can do that for one person and then move on to the next person. So unfortunately, that intervention, although very effective, wasn't designed with the setting in mind that it was going to be implemented in. And that's really unfortunate because it's a spectacular intervention. And incontinence can lead to so many other problems. There's tissue breakdown that can happen. There are diseases that are more likely to occur. People can go into the hospital. That can be a potential lead into death as a result of this. So it's something that's so important that we could do something about. But here was a spectacular intervention that just wasn't doable in that setting. Medically related, hydration. Feliciano et al. Looked at dehydration and barriers to hydration. So when we're thinking about dehydration, that means that you're not drinking water. Well, that doesn't pass the old dead person test if you're a behavior analyst. So we're going to talk about hydration instead. And she created a functional assessment of barriers to hydration. What might be keeping you from being hydrated? And it was basically an informant-type functional assessment, asking questions, looking at antecedents, information knowledge, consequences, that sort of thing. If anyone's familiar with the performance diagnostic checklist, it was built off of that. And she was able to show that they could increase hydration for folks who were at risk. And we've replicated that in my lab with folks who have been hospitalized for dehydration, which is a target for many hospitals. We're also currently looking at medication adherence. Medication adherence is a major issue for older adult populations, likely because of the very complicated medical regimens that they're on. So it's not that people are saying, I'm not going to take my medication. It's that when you've got that many medications, it can be tough to stay on track with everything that you need to do. And not doing that then sets you up to potentially experiencing some pretty bad stuff. As far as goals, we have a chapter that we wrote looking at research and clinical considerations when doing behavioral gerontology, and made a couple different recommendations for what behavior analysts might consider their targets. And one of the things that we really emphasize there is you want to get some solid baseline data, because oftentimes we may not be looking, if it's a skill that someone's losing, it may not be possible to reestablish that skill. But it may be that we can slow down the decline. And it's helping folks recognize that with some solid baseline data, you could recognize kind of the deterioration rate and then demonstrate an effect by simply decreasing that deterioration rate, looking at the slope of what you've got. And also the importance of treatment and support plan goals and normative data. We see a lot of times that folks who engage in some more challenging behavior tend to get the short end of the stick when it comes to staff and their patients. And challenging behavior might be less tolerated for those folks than it would for others. We have a gentleman that we've been working with who is referred for spitting, and it's a pretty nasty, large amount of phlegm that he's spitting. He's been medically evaluated. They can't find anything medically wrong that's causing this. But he was potentially set to be discharged from a nursing home. And I don't know if you've ever been around many nursing homes. It's kind of rough when you're discharged from a nursing home, because where else do you go? Another nursing home. So you got to find one that's willing to take him on. And for this guy, he was spitting, and one of the times we were doing observations, we saw someone else spitting. And we said, well, why hasn't she been referred? They said, well, her spit isn't as gross. And she's spitting into the garbage, and he isn't. So we said, okay, so we're not going to get rid of spitting. That just doesn't seem necessary, because there's still, nobody spits that much phlegm. That's weird. So there's got to be something going on, but let's give him an appropriate place to spit. So we actually did a series of interventions where we got him spitting in trash cans, and we created our own. The nursing home staff have told us that we should patent these new trash cans, which are really just PVC piping and a trash can that pivots. It's pretty low tech, but they thought it was spectacular, and he spits into those now just fine. So what we did was we identified not what staff wanted, which was get rid of it, but instead said, what would be normal, what would be acceptable? And they had someone else who was already spitting into the garbage. That became our goal, not to get rid of this behavior necessarily. And then looking at socially acceptable goals, can we look at skill acquisition and see what would be useful for this individual? The study by Michelle Bourgeois that I put up there, in the discussion section, there's a point where she identifies that the caregivers were not happy with that intervention because that wasn't a concern for them. Social interaction was not an issue. For them, there were disruptive vocalizations, aggression, other interactions. Those were things that they were concerned about. So they weren't all that excited that you could get someone to have a conversation. So when we're thinking about our interventions, we have to think about what is going to be helpful. So although I just said, don't go by what staff say at the same time, let's go by what the caregivers help identify as well. Because if we come up with a spectacular intervention and it requires someone else to help implement it, if they're not on board with it, we're not going to get that intervention in place. Some guidelines and restrictions. Well, what are they? What do we have available when it comes to providing supports for older adults? Well, one area we can look is something called PASSAR, Pre-Admission Screening and Resident Review. And PASSAR builds off of the Nursing Home Reform Act, which was part of the Omnibus Budget Reconciliation Act of 1987. And OBRA 1987 provided a federal mandate that behavioral interventions be used prior to chemical or physical restraints for older adults in nursing homes. Since 1987, there's been a federal mandate that you have to use behavioral interventions with older adults. Super cool, but nobody does. So we see PASSAR developing, where there are requirements on basically what you can do with folks that are in your facility. And one of the key things here is that individuals with disabilities cannot be required to be institutionalized to receive public benefits that could be furnished in community-based settings. PASSAR can also advance person-centered care planning by assuring that psychological, psychiatric, and functional needs are considered along with personal goals and preferences in planning long-term care. And PASSAR, which I believe is enforced in part through the Affordable Care Act, is causing a lot of nursing homes to reevaluate what they're doing. Because, and I don't remember if it's on the next slide, nope. There's a requirement related to medications. and having a proper diagnosis associated with that. You might be surprised to know that in most aging settings, there is not an enforced requirement that a medication match a diagnosis. So that means that antipsychotic medications can be used even though there's no diagnosis that matches the prescription of that medication. Which is really where I was getting at here with the medication, where advocacy becomes key when working with our older adults. And what I've found is that I'm oftentimes in an interdisciplinary group, but sometimes I feel like I'm the only person that's looking at certain things. And it causes behavior analysts to kind of step out of their role and remind everyone of things that maybe fall within their realm. And oftentimes for me, this is around medication and recognizing the potential concerns of certain medications, specifically psychotropic medications. I don't know if anybody saw this. This is just from February 5th. It was an NPR story that risky antipsychotic drugs are still overprescribed in nursing homes. So OBRA 1987 was supposed to address this. 30 years later, it's still an issue. It's still a major problem. This is a study, Dementia Antipsychotic Withdrawal Trial. This is a randomized controlled study, extremely well done, that looked at the impact of psychotropic medications, specifically antipsychotic medications, when used with older adults. Now, the reason this is important is because the FDA has issued a black box warning against using antipsychotic medications with older adults with neurocognitive disorder because of the fact that they double the risk of death, and they have not been shown to be very effective at addressing problem behavior outside of sedating effects. So in this study, we have the number of people at risk, and basically what this means is death is going along the y-axis. It's survival. So you start with 100% of the people in the group, and then as it goes down, that means more people have passed. And then across the x-axis is time. There we go. Whoops. Okay, so where that arrow is the point at which these groups separated. So both had been receiving antipsychotic medication, but at that arrow, we switched to a placebo for one group, and we continue with antipsychotic medication for the other group. And over time, we see those separate out. And the only explanation for that separation is the medication that folks were receiving. For my dissertation, we looked at the acceptability of different interventions for working with older adults. And what we found was that, among other things, Risperdal was endorsed as a pharmacological intervention used in the 6 months prior for 28 of the 37 respondents. And these were staff who were part of the behavioral intervention treatment team. So these were the folks that were making the decisions on what would be done, indicating that Risperdal was quite familiar and acceptable as a medication used to control behavior. Again, even though we have a federal mandate against it and the need to use behavioral interventions before that. But here's the kicker. On several occasions, when asked for examples of behavioral interventions, medication was listed. So it's great to have OBRA mandating that behavioral interventions be used prior to chemical or physical restraints. But if people don't know what a behavioral intervention is, we don't see much adherence with that. And these folks definitely did not think that they were out of compliance. I doubt they would have answered that question if they thought that they were. Can't see that I'm really pushing this button hard right now. There we go. Here's a story from 2015 in NPR. Behavior therapy helps more than drugs for dementia patients. Isn't that cool? 3 years ago, there was a story in NPR about behavior therapy beating out medications for effectiveness. And in response to that, Claudia Drossel and Miranda Trahan talked about it and how it relates to behavior analysis. And they mentioned that we have a robust literature that supports behavioral interventions. In fact, every one of these studies is a demonstration of a functional analysis and function-based treatment for addressing problem behavior for older adults with neurocognitive disorder. Really cool. This article came out in November. An overview of systematic reviews of pharmacological and non-pharmacological interventions for the treatment of behavioral and psychological symptoms of dementia. Their conclusion, and I'll read it for you, says, although some pharmacological interventions had a slightly larger effect size, current evidence suggests functional analysis-based interventions should be used as the first-line management of behavioral and psychological symptoms of dementia whenever possible due to the lack of associated adverse effects. So we've got a lot of support for using behavioral interventions to address the challenging behaviors that folks experience with neurocognitive disorder, and more support for that than medications. But we find that that is a constant battle. And part of the challenge is doing that effective medical rule-out and then designing a functional analysis. And we're running short on time, so I will not describe how you might design that functional analysis, but I'm happy to as soon as I'm done. Drossel and Trahan said, from a principled behavioral change perspective, serious efforts of using behavioral interventions must include the following: systematic rule-outs of drug effects, undetected illnesses, or pain as a precipitator of acute and abrupt behavior change, and, if indicated, treatment of delirium with first-line non-pharmacological interventions. They also had this quote in here. It says, individuals with neurocognitive disorder are a vulnerable population with an already compromised central nervous system, frequently multiple comorbidities, associated use of many prescribed drugs, and age-related changes. Together, these factors alter pharmacodynamics as well as pharmacokinetic processes. Indeed, the high use of prescription medications and the sensitivity of adults aged 65 and older to adverse drug effects has prompted the following heuristic. Any new symptom in an older patient should be considered a possible drug side effect until proven otherwise. Any new symptom in an older adult should be assumed to be the result of medication until proven to not be. That's very powerful. Just to give you an idea, this is Bert. This is the guy that was spitting. These are the medications that he's currently being prescribed. I don't have my notes in front of me. This is the one time that I benefit from those. But I think at least half of these carry either a black box warning or a specific warning against being used with older adults and against being used with older adults with neurocognitive disorder. Some of them are anticholinergic, which has been shown to be a very bad medication for use with older adults. And then some of them just simply have, there's also, if I remember correctly, 2 that have an interaction effect. And we were the first people to point this out. And he'd been on this medication regimen for quite a while. In fact, we made such a stink initially. Levsin was not the first medication that he was on. That medication was designed to reduce his ability to spit. They were giving him a different medication before that. It was actually eye drops. They were giving them to him in his mouth. And I thought, that is the weirdest thing I've ever heard of. So my neighbor's a pharmacist. I went to him and I said, hypothetical scenario. In what world would someone consume eye drops? And he said, well, that's something they do in hospice to help prevent someone from aspirating on their own saliva. Well, this guy isn't on hospice. And that effect, that drying up, is considered an anticholinergic effect. And that drying up means dehydration. And dehydration means the possible of delirium, the possible of urinary tract infections, and a whole slew of other things. So this medication that they were giving them to address the problem behavior was actually causing many other things. And in the end, It wasn't that we had to get rid of it, we just had to have him spit in the socially acceptable area. Some of the things that we end up thinking about for our functional analyses, social negative reinforcement. It's an interesting thing when you think about aging settings. Generally, folks aren't being presented with academic tasks at that point. So when you get folks that are really consistent with their Iwata et al. 1982-1994 functional analysis, they're like, oh, we've got to come up with demands. In fact, one of the published studies on functional analysis with older adults actually created demands that did not exist to replicate that condition, which I thought was really sad, because why are we testing a condition that isn't relevant for someone? But we do see that there are aspects of social negative reinforcement that can exist. And a lot of times they're around care tasks, where aggression during a care task will get you a momentary break. Staff will back off for a second. They'll take a breather. And when staff are doing that care task fast, because they've got to get in, they've got to get it done, engaging in that aggression can slow them down. And they're not there to slow down, so they're trying to go faster. This person's becoming more aggressive. They're pushing faster. It becomes this cycle. And we've shown that a simple intervention of slow it down, give them a little break, non-contingently, can actually eliminate the aggression that we see. Discriminative stimuli. I do not have time to get into my long discussion on discriminative stimuli and the potential impact that Alzheimer's disease has on discriminative stimuli. But suffice it to say that from a behavior analytic perspective, if I was going to explain dementia to you, I would say that it's a progressive disease that inhibits stimulus control. So things that you used to do in the presence of a certain stimulus, you no longer do. When I ask you to tell me about what you did in high school, you are no longer able to. That's a stimulus control issue as far as we're concerned. When presented with an activity that you used to do and you're not able to do it anymore, that's a stimulus control issue. So when we do a functional analysis, we actually have to really work hard to establish stimulus control, because otherwise our functional analysis conditions may not do anything. And there are a couple of published examples where folks got undifferentiated results that are probably because they didn't program discriminative stimuli into their functional analysis. And you have to keep in mind the fact that anything you do is likely going to need to be implemented by staff, not you. This slide is just showing a couple of studies that specifically targeted older adults with intellectual and developmental disabilities. I definitely don't have time to go into each one of these. But what's interesting is that I say it's older adults, and I have that in quotation marks, because you can see two of the people are 48 years old. And I think that if I were to walk around and tell anyone in here that's 48 or older that they're an older adult, I might get punched. And what we know, though, is that for folks with intellectual and developmental disabilities, they experience age-related changes earlier. So we will include them in our group that we'll call older adults, but really this is not a robust literature when it comes to working with older adults. But again, it's shown that our methodology works just fine. So, what do we take from this? We know that our aging populations experience a number of changes, a number of physiological changes and environmental changes. And providing quality supports requires that you're aware of those and you know how to assess for the impact of those changes. It requires identifying that we may need to put additional supports in place. It's interesting, when we're working with children, we'll do anything we can to enhance the stimulus control. Like, we'll color code different things. We'll put pictures on bins to help folks know how to sort. And then we take that away as you get older. You're a grown-up now. You should be able to do this without us telling you to do it. And as a result of that, we see this resistance to putting those things back in place when working with older adults. And they say, we shouldn't have to do all these things. They should be able to do it. Well, they have a progressive disease if they have a neurocognitive disorder. And even if they don't, it's not a bad thing to ensure that somebody knows what they're doing. How many of you in the past week went to the wrong, I call them cupboards. Does anyone else call them cupboards? No, 3 people. I don't even know what the other word is.
My grandmother calls it
I spend a lot of time with older adults. Cabinets, I guess, would be the term that most people, I get this look from the audience, old Mother Hubbard. Yeah, so how many of you in the past week opened the wrong cabinet when looking for something? Yeah. Wouldn't it have been great if you'd had a picture on there? You go to grab, oh, that's not the right one. Let me grab this other one. But if your friends came over and saw that you have pictures on your cabinets of what's inside them, it would be ridiculous. So we have a bit of a stigma that we have to get past to provide some of those supports. Behavioral gerontology requires an awareness of these needs and combining them with the skill set that behavior analysts already have. And doing so can lead to a behavior analyst that can provide supports on a much wider range. I won't do that, but just keep in mind the total numbers. There are a lot of different areas that behavior analysts work in, different populations. Some people work with autism, some people with developmental disabilities. We've got organizational behavior management, traumatic brain injury. We have clinical areas. There's one thing that's common across all of those. They will all eventually be older adults. So a solid repertoire in behavioral gerontology really sets you up to be able to work with a lot of different populations and provide supports that a lot of people aren't thinking about. And just a plug for a manuscript that we wrote on expanding the consumer base for behavior analysts. In this article, we talk about what might you do if you're interested in expanding. And we've got a couple quotes. I'm not going to read those. We're going to move on. But the reason that I'm talking about it is that there are some ethical concerns when you move into a new area. You want to provide services within the boundaries of your competence based on your professional history and training. That means that we should be able to look at the training that you receive and identify a scope of practice, things that you have been trained and supervised to do. And you have to be careful about practicing outside of those areas. You want to remain aware of the current information in the field and the activities by reading the literature and attending professional meetings. And behavior analysts should only accept clients when they're qualified to do so or are supervised in consultation with behavior analysts with the appropriate credentials and training. And what's really cool is that that's what Melmark is doing. They're identifying different areas that they want to expand their services and bringing in folks that can help them do that. So it's super cool that that's something that is on the forefront for Melmark. And for those of you who are associated with that, know that although it may seem like just kind of everyday sort of things that you're doing, you are well beyond the rest of the field in thinking about this and incorporating this. Some of the other things that we have on there, contacting the literature, contacting different professional groups, pursuing retraining, supervision, and professional credentials. There really aren't any credentials that are required to work in behavioral gerontology. There is a specific certification that's available for providers who work with older adults with intellectual and developmental disabilities. I have not had a chance to pursue that certificate just to see what things are added. I'd like to see what else they're talking about. But it's not one that necessarily opens you up for additional funding. It's just a demonstration of additional training. And same with aging. I have a certificate in gerontology. It really doesn't mean anything when it comes to billing, but it means that I had training in all these different areas before I was practicing, and there are a lot of folks who don't. That's it. Thank you. 1 minute for questions. Oh, yes. Yep.
Thank you for the presentation. I would like if you could share your thoughts in regards to normalization. When you think about mental age versus what's the word? Mental age versus age appropriateness when choosing or helping individuals in social engagement?
That's a good question. Because a lot of times we see that not just for folks with intellectual and developmental disabilities, but older adults in general. Kind of this odd line of we want to find something for them to do, and the things that we find sometimes are not necessarily age appropriate, but maybe something that someone is interested in. And that's a little bit of a minefield, really, to step into and make recommendations. But for me, part of what I look at is, can I demonstrate that this individual has a clear preference for one set of stimuli over another set of stimuli? I see a lot of times in nursing homes, folks are provided with dolls. And you'll see, especially older women walking around the nursing home with a doll, and they're holding that doll, rocking it like it is a baby, pretending like they're feeding that baby. And my question is always, is that person's most preferred stimulus, or is that the only stimulus that you've tried? And oftentimes I get that it's the only one that they've tried. So I'll work with those facilities to conduct different preference assessments, and I'll usually follow that up with a reinforcer assessment and see if basically when I pit that stimulus against something that maybe is more age appropriate, what will that individual engage in? And for me, part of what becomes extremely important is incorporating that individual's preference. And if I can make it seem more age appropriate, I will. Like if we're talking about someone, I'll go into facilities and they'll have people coloring, and it'll just be a picture torn out of a coloring book, like a child's coloring book. Well, there's plenty of adult coloring books that we can give them access to. And one of the things that I'm still kind of blown away by, at least here, I think it was over in the Meadows building, where they have folks painting on cloth. And they can really paint whatever they want, and then they're taking that cloth and turning that into placemats. So the activity, which is they like to color, is turning into a functional skill that allows them to create something that can then be sold. So that was my way of very carefully not answering your question and saying that I will usually try to not make that judgment call on my own, but instead use data from the individual to try and guide that. Is that okay? Great question. Any others? All right. Well, thank you.